Everybody. I'm Dr. Wilson, and thanks for attending. Today, we're going to talk about a very important topic that's oftentimes a little bit ignored, but is quite important, and a lot of people have quite a few issues with it, and that's bladder urgency, frequency, and urinary incontinence. I welcome you all, and we'll also be able to answer any questions at the end, and we'll get started here. So next. So, bladder and bowel issues are certainly quite common, but they're not inevitable, and they are very treatable. So if you have some of the symptoms of urinating, about every couple hours during the day or more, having the feeling that you can't stop your urination and have to rush to the bathroom, this is a big one where people come in and they tell me that their entire life revolves around planning activities around the bathroom, and they can't go to sporting events or their grandkids, baseball games or any of that, just because they're just worried when they're going to have incontinence or this urge to go and not be able to find a bathroom. And that leads to also, just it affects how people live, where they eat or drink, or how much they can, going to restaurants. And really another big one is getting up multiple times at night, because sleep is so important for overall health. And so if someone's getting up over 2 times a night to urinate, there's pretty strong evidence that affects pretty much all facets of your life due to sleep deprivation. Next. So, that kind of leads to questions and suffering in silence, like, will this ever end? Can I ever get back to my normal life? Will this affect my job performance? And can I even hold a job, do normal activities? And just essentially, for a lot of people, it unfortunately leads to being afraid to even leave home. And so just know that you're certainly not alone, and that over 64% of people who have these type of symptoms don't seek treatment for them, and they really are suffering in silence. And then over 48% of people who have these symptoms also report a loss of confidence in many activities of daily living. And as the earlier slide said, it's over 1 in 6 people in the general population that has these symptoms. So we're talking about a lot of people who are having these issues, and a lot that aren't really getting treated either. But there are options for treatment, and that's what we're here to talk about today. So, certainly incontinence affects people of all ages, both genders, and overactive bladder can affect young children all the way through centenarians. And so a lot of times also bowel and bladder issues are connected, where due to the common nerve path, those with overactive bladder also have frequent stooling, and that opens up a whole other set of issues for them as well. There are options, which we'll talk about later, which can target both at once, just due to the common pathway and how close they are anatomically. And just to say again, 1 in 6 adults reports some type of either bowel or bladder issue, and with bladder issues being even more common. And we're talking about, now with the growth of the American population, almost 50 million adults in America have this. So a lot of people do, and only a minority of them seek treatment. And the same thing for bowel issues, that nearly 1 in 10 adults have some type of bowel issue as well. Next. So there's a lot of different causes of bowel and bladder issues. The common lifestyle causes are things like caffeine, sedentary activity, having a higher body mass index can all contribute to having overactive bladder. For most people, interestingly, it's multifactorial, and a lot of patients don't have a clear cause. They say, 18 months ago or a year ago, I didn't have these issues. Now all of a sudden, I'm finding myself getting up multiple times a night to urinate, and they don't have an infection, don't have any clear-cut cause, and it's probably a complex interplay between the firing of these nerves, the muscle of the bladder, and all the complex anatomy and the pelvic floor that contribute to this overactivity. So for a lot of people, there's no specific one cause, but they still kind of have progressive issues, and a lot of times when these issues start, they continue and don't get better. So they kind of come on suddenly, and then unfortunately they're either slightly worsening or they stay the same, but the same is causing all these changes in their daily life. Certainly medications or supplements, caffeine being a very common one, and certain water pills, or what we call diuretics, will make you urinate more frequently, and so the increase in urine frequency will lead the bladder to contract more, and in some people the bladder accommodates that, and others the bladder just starts trying to expel that urine more rapidly, and they get frequency of urination. And anything that affects the pelvic floor, we see this very commonly in women after childbirth, any pelvic floor injury, either a car accident or and even surgery. We see this a lot after certain spinal surgeries, and or neck, cervical neck surgeries or injuries, where all of a sudden there's quite a bit of overactivity, urgency, frequency that ensues after that. And when you think about these injuries or pregnancy, or these are kind of not thought about, what urgency, frequency, but this is what's coming into my clinic, and it really does bother people. So the back surgeon will treat the spine injury, but the ramifications of that and the urgency and frequency is actually, once that heals, what's keeping someone from leaving the house. So it is kind of a very common thing, and we handle that all the time. Every clinic that we have, we see patients with this. So just know that the good news is that there are several different treatments. We'll go through each one individually, and that that the vast majority of patients, or nearly all, can experience some, if not significant, relief from this. So we kind of touched on this a little bit, that when someone's urinating, it seems like such a seamless act when everything goes right. Just like when you're running, when you're 20 years old and you don't have any joint pain, it just seems so free and easy. But then, if you have a little arthritis and you're 65 years old, all of a sudden, you realize how much has to go right just to even walk properly, or certainly run. Well, same thing with the bowel and the bladder. There's a very complex interplay between the brain, the spinal cord, the nerves that come from the spinal cord and go to the muscle of the bladder, and then there are neurotransmitters that then allow the muscle to contract, and then the muscle actually has to contract. The urinary sphincter has to open up properly, and then the urine comes out. When all of that happens, easily or seamlessly, it seems like an effortless thing, but any one of those pathways can have issues, and then we see problems ensue. So there are three different main types of urinary incontinences. The first is stress urinary incontinence. That's most common in women after childbirth. Very common, just due to kind of stretching of the pelvic floor, and also men can have incontinence when they have their prostate removed. And there's a whole set of reasons, other reasons as well, but that's characterized by coughing, sneezing, laughing, and having incontinence or leakage of urine. basically when you're putting pressure on the bladder, the sphincter, which is meant to prevent the bladder from leaking urine inappropriately, is not strong enough, and that leakage ensues when enough pressure is generated that overcomes the sphincter. So that is more treated surgically with mid-urethral slings and other type of minimally invasive surgery. And that is not usually caused by urgency or urge incontinence, which is kind of the focus of this talk. But that's a very important cause of incontinence, and it's quite different from the urge incontinence. And then we can do next. Yeah. So the second type of urinary incontinence is when you have urinary retention, meaning that the bladder is too overfilled. The body doesn't have the normal feedback mechanisms to let the person know that there's too much urine in there. The bladder can't hold it anymore, and then there's no more room for urine to come in the bladder. So it basically will have incontinence or leakage of urine. A lot of times we see this in patients with long-standing diabetes, or in men who have blockage of the prostate for a very long time, and it's not unblocked timely, that the bladder muscle starts to degenerate a bit, and it holds too much, and then all of a sudden it can't hold that much anymore, and it will leak urine. Diabetics oftentimes after a certain amount of time don't have the feedback mechanism, and so they're holding 2 or 3 or even more times the amount of urine in the bladder that they should, and it overwhelms the sphincter in the bladder, and then there's urinary leakage. Now, that is treated most frequently with needing a catheter. There are other types of tubes that can be used to drain the bladder. That's probably the least common type of urinary incontinence, but it is something we see frequently in clinic as well. And then next. So probably the main focus of this talk is the third type of pathology to affect the bladder, and that's overactive bladder. So urge incontinence is where the bladder is not fully is not full, and it inappropriately thinks that it is, and then contracts prematurely. So a normal bladder should hold about maybe 2 cans of Cokes, or something like 600 cc's. So patients with this issue sometimes only hold 150 cc's, so maybe a quarter as much as they should, or maybe half as much as they should, and so the contractions occur without warning. That's when people are running to the bathroom. When those contractions happen, then the sphincter is overwhelmed, and then there's leakage of urine. They can happen without warning, or they can even happen with some type of precipitating event, like drinking water causes the overactivity, or some eating even some type of food can trigger it. And so or just even sitting on the couch, we see people have this issue. So it's basically characterized by this uncontrollable urge to go, urinating much more than you should and much more frequently than you should, and also urinating a lot at night, which adversely affects sleep. And there's a feeling, and I see this a lot, or I hear this a lot in clinic, that the patients say, "Oh, well, I'm never emptying my bladder." We actually then get an ultrasound of their bladder, and their bladder is completely empty. So the bladder just has this constant tension, and people think that they are not empty when in fact their bladder is completely empty. It's just the bladder is giving them sensation like they always have some type of fluid in the bladder. And next. So fecal incontinence has many different causes as well, but it dovetails in with the urge and urge urinary incontinence. The nerves to the rectal area and the lower part of the colon also come out of the same exact place as the nerves to the bladder. That's the, not to get too technical, but the S3 area. So of the sacral spine, the lower part of the spine, these nerves kind of fan out from the spinal column, and then they innervate the rectal area and then the bladder itself. So a lot of patients who have urge urinary incontinence also tend to have fecal incontinence. And also, interestingly, we'll talk about that a little bit later in the talk, the treatments that help urge urinary incontinence also help fecal incontinence as well for a lot of people. And so same thing as urge urinary incontinence, there's kind of a without warning involuntary loss of stool. That can be accompanied by involuntary loss of urine at the same time or just before or after. Same thing as the urinary habits that you end up planning activities around the bathroom, um, and and then having some type of small bowel movement every time you urinate, which is not normal. Most people have bowel movements once a day or twice a day, some every other day. But patients who have this are sometimes stooling 6-8 times a day, and it's because of a disturbance in this shared pathway between the bladder and the bowel. So this can be addressed with both on both ends through certain treatments that are aimed at that nerve. Next. So to get into some of the treatments, there are many ways to treat urinary incontinence, and those include lifestyle modifications, medications, injections in the bladder, and then sacral neuromodulation. So the you have to basically just talk to your doctor to optimize your plan. A lot of times we go in kind of a stepwise fashion where we recommend lifestyle changes. Most people who are coming to me as a urologist have already, tried the Kegel exercises, the weight loss, have, tried to eliminate caffeine, not drink any fluids a few hours before bed. Many of them have already had 1 or 2 medications, and these haven't worked, and they're kind of looking to a urologist for the next step in management. And we'll go over each and every one of those, including medications, Botox, sacral neuromodulation, tibial nerve stimulation, and then the newest option, which is an implantable tibial neuromodulation, which has some exciting new prospects for that. So next. So kind of touched about on these earlier, but there are lifestyle changes. The great thing about these things is that really it's sort of a free lunch, and that changing your diet, trying to avoid offending foods, exercising more, particularly walking, seems to reduce inflammation in the body and have a whole constellation of effects. It's not like you need to try to run a marathon, or that you need to join a bodybuilding competition to get these benefits. I mean, just increasing your walking every day can help the bladder quite a bit. And biofeedback, when trying to suppress the urge, in some people that actually works, is almost retraining the bladder. We call it time voiding. So kind of suppressing the urge and trying to urinate every 3 hours instead of every hour and a half and 2, and then just spreading it longer and longer. For some people that works, for many it doesn't, but really there's no downside to trying something like that. And physical therapy, we at Avita health system, we have some of the best pelvic floor physical therapists I've ever worked with, and so they can give you kind of tailored plans. When I was studying the pelvic floor in residency and medical school, I just was amazed at how complex it is. So a pelvic floor physical therapist is a very valuable tool to kind of diagnose specific issues within the pelvic floor and give exercises beyond just Kegel exercises that may help a subset of people. And it's surprisingly helpful in many of these cases. But oftentimes people need a little bit more than just lifestyle changes, and that's where some of these other therapies come in. So the oral medications for overactive bladder are mainly in 2 categories. There are anticholinergics. For those of you who are listening to this talk, you probably tried them before. Oxybutynin, also known as Ditropan, Vesicare, Sanctura, also known as Tropium. I mean, there's a whole subset of these medicines, and that's the one class. For a lot of people, they do work. The effects are modest, mild to modest at best. All of those medications in that class do cause a dry mouth to a certain extent. They can cause constipation, which constipation can make urinary habits worse because the bowel and bladder are so close to each other. So when someone gets severely constipated, it just makes all this worse. And so, their side effects are oftentimes prohibitive. The other class of medicines are the beta agonists. For those of you who have overactive bladder, you may have tried those. Those include like mirabetril, also known as mirabegron, or virbegron, also known as Gemtesa. Those medicines do work. Again, their improvement could be mild to moderate. For some people, that's all they need. And I do use a combination of these medicines frequently. The beta agonists, particularly mirabegron, some people can cause higher blood pressure. Gemtesa is a little better tolerated. Right now, for both of them, we're just having a lot of problems with them being very expensive on a monthly basis. So particularly Gemtesa. So, I mean, worth trying. Have their pluses and minuses, but oftentimes I'm seeing patients who are only partially helped or just really aren't getting over that hump. To where they're now more functional in their life. I mean, they just need to get better enough where they're not prevented from doing the events in life they want. And for some of the medicines do that. For others, it's kind of a mixed bag. Next, so there's kind of a category of advanced therapies, and so in terms of both bladder and bowel control, for the bladder control, we're really talking about all these what we call sacral neuromodulation. So we're basically stimulating the nerve that goes to the bladder in some way, either more directly through that S3 nerve that I had talked about before, more centrally, or more recently, trying to basically stimulate that on the periphery or the lower part of the body, which you can interestingly do through the tibial nerve, which is by the ankle. And then that feeds back into that same area to do some of the same effects. And then there's also injected medications we've touched upon, and we'll talk a little bit more about Botox. Botox does work, and for some people it is worth trying. I use that quite frequently in my practice. And I think the next slide, or one of the next slides, has kind of the pluses and minuses of that. For bowel control, the injectables don't work as well, so the Botox is not as effective. For the bowel control, really the sacral neuromodulations are the best thing to try when you have urge incontinence of urination and also of stooling. Something like an InterStim implant has the best chance potentially of addressing both, because as I said before, the nerve roots that come out and go to both the bowel and the bladder are from the same exact location. So that's something that we kind of use to our advantage when patients have both issues going on at once. Next. So this was the slide that I talked about on Botox. So Botox does work. I find that it is stronger than the medications overall. So it's a reasonable option in someone who is not responding to medications or has side effects to the medications. And in fact, most insurances want us to document that a patient has failed a couple medications before they'll even approve Botox. But typically, Botox that is given in the bladder is given between 100 and 200 units. A typical dose, to my understanding, in the face is something like 50 or 60 for cosmetics. So it's a pretty strong dose in the bladder. The kind of amazing effect of that is that for some people, it eliminates all the bad, like the inadvertent or inappropriate contractions, while maintaining normal function. There is a risk of having retention there, but in patients who have urgency, I see that very seldomly, that they have new onset urgency. So for some people, it's a real game changer. At Avita, we do that in the office and do it quite successfully, particularly in women. Men oftentimes have to be in the operating room, so there's definitely a downside there, that needing anesthesia for it, because this is something that wears off, just like it wears off in the face or cosmetically, it wears off in the bladder. Your body will break it down. So typically in about 6 months, someone's going to need another injection. So if someone needs to go to the operating room every 6 months, that's a problem. And there is a variance on how much it works and for how long it works. But for those that get a good relief from it and are able to have it in the office, then I think it has its definite advantages with some key downsides. Next. So, the probably the let's say the first or one common next step above Botox is something called percutaneous tibial nerve stimulation or neuromodulation. So essentially, it's something that you can do in the office, and it works by kind of using the normal stimulation that the tibial nerve has to that sacral nerve area in the spine that then will calm down the bladder. So it works similarly to the ones that are straight at the source, but it works at the ankle level and will kind of amazingly calm down the bladder by stimulating a nerve on the back end of your ankle. So basically, it typically is about a 30-minute session a week. The picture on the right of the patient who's reading a book is pretty typical. It's not painful. It's a very small needle that patients barely feel. It's like less than the size of a diabetic needle. And then once it's in, it's not painful. Patient relaxes, gets a treatment, and then over time, there's good evidence that it kind of feeds back to the bladder and can reduce that urgency and frequency by kind of affecting how the nerves interact with the bladder. So after that, if someone is having good success with that, we'll then do maintenance sessions and just have long-term relief. But a maintenance session is coming to the office and getting connected, just as you see on that picture. And then after 30 minutes, you just go about your day. There's really no preparation. So, looking at your phone, reading a book is completely reasonable during the treatment. Next. So kind of the next step above that is as a more permanent implantable device. This is a new product by Medtronic and is quite exciting. So essentially, it's when you saw what's going on the previous slide, it's doing that at all times, but doing that through a very small device that's implanted behind the ankle that gives continual stimulation to that nerve that feeds back to the bladder. It's basically delivering a whole variety of programs and stimulation. There are certain schedules that can be programmed remotely. It is, MRI compatible, which is very important for patients down the line. It's not something a lot of patients think about, when they're initially getting this, but then as other health issues arise, MRIs are becoming more and more important and better, and we use them for a wider variety of clinical reasons. So having it both 1.5 Tesla and even the stronger magnet 3 Tesla compatible is really a game changer for these. And the other thing is that just local anesthesia is needed, so it's not a procedure in the operating room, and so the recovery time is very quick. It's a very small device, so this is just being kind of brought out and developed and by Medtronic pretty much in the last couple of years. It's been in development for a while, but kind of exciting new technology that is the next level above the office stimulation and allows a little more level of sophistication long term. And next. So the InterStim system is kind of the system that has been around the longest and has had significant improvements over the years, though. But this is something that was kind of discovered, I believe, in the 1990s, where if a device is implanted where there's a lead stimulating that one particular nerve that goes to the bladder, there can be a very powerful calming down of the bladder. And a lot of times this will work when nothing else does. So I'll have patients that are, as I talked about earlier, that these are the patients that say, my whole life has changed since this happened. I've tried all the medicines, the Botox didn't work for me. I need something. And they're even talking about whether they should have their bladder out because they need to have something that allows them just to live life. So Clearly, this is a lot less invasive than removing the bladder, and is something that can be done in a quick procedure. The first step is an office procedure where a lead is placed, which is local numbing medication, to stimulate the nerve just for about a few days to a week. That's called a peripheral nerve evaluation. So the great thing about that is that if patients don't respond to it, then that's just easily taken out in the office, and no need for anesthesia for any of it. I can say that the patients that are coming with me and we screen for this procedure, pretty much almost everyone who has this procedure then wants the formal implant. The formal implant is actually a procedure in the operating room where a formal lead is placed in near that nerve, and then there's a battery generator, which is what you see kind of in the circle, the first circle to the left and on the top of the screen. So it's a small battery. The batteries, when I first started, sometimes would only last 2 or 3 years. Now with the improvement in technology, the batteries themselves are smaller, but they last over 10 years, sometimes even 15 years. The one also big advantage of something like the InterStim is that if you're trying a medication, it takes about 3 weeks to start working. Then, if it doesn't work, then that's it. Either it works or it doesn't. Sometimes you can increase the dose, but the side effects increase. With the InterStim, there are dozens of different programs because you have 4 different parts of the lead one can stimulate. So sometimes part 1 works better, sometimes part 4, sometimes part 1 and 4, 2 and 3. So and that can be changed wirelessly through a phone app. And so if something isn't working as well, someone can get potentially immediate relief just by changing what's stimulated on this implant. So, and you don't have to wait 3 weeks for a medication change. You pretty much sometimes can wait as little as 3 minutes and notice a difference. So the level of sophistication with this is great. And a lot of times this will work when nothing else will. And once it's in there, then you can resume normal activities. So it's well seated in the body, and then the body kind of incorporates that into the tissue, and it just continues to work in the background without really any interference or any modification needed. And then next. So this is kind of a slide on that peripheral nerve evaluation. So basically an office procedure is done, and that's kind of what you see on the patient to the right, where a external battery is placed. If this works and the response is good, then the formal battery will be placed in the operating room. But if this doesn't work, we can just basically disconnect the battery, gently remove the lead, and we just put a Band-Aid on where we removed that. That gets removed the next day, and patient is no worse for the experience. But the vast majority of people do notice a significant improvement. And if you notice an improvement with the nerve test in the office, which is done just using landmarks and a little bit less specifically in the operating room, then someone's going to get an even better response in the operating room because the lead is more sophisticated. The way we put it in is even more precise using X-ray and kind of precision technology. So those that get a good response with something in the office get an even better response with the formal implant. But that's what it looks like. It is something that is kind of carried around for a few days with you, and the patient will do a voiding diary. So basically, they'll write down the number of urinations and leakages or incontinences that they have, how many times they're getting up at night before the implant is placed, and then they'll do that for the few days after, and we'll compare. And if there's a significant improvement, we proceed to the formal implant. So the the formal implant is was kind of pictured in previous slides, and it as well is now MRI compatible. Just as a little caveat for those who have this procedure, who are listening or are thinking about getting it, is that it does need to be put into MRI mode, meaning that it has to be deactivated through the phone. I've had a couple patients get an MRI and then the system intentionally turns itself off. So I mean, it protects itself, but then they're like, oh well, my urination problems are back. Well, if you had an MRI and you don't put it in MRI mode and take it off MRI mode, then it will automatically turn off. So but that's good that it can do that, and it's sophisticated enough to do that. But just know it is MRI compatible, and it's probably very few people listening to this talk will go throughout their entire life without having at least one MRI. So during their life at some point. So this is this is a very good thing that this is able to be accomplished through the system. And next. So some of the data on the system. So there's 84% satisfaction with those who use it for bladder control. I would say that I have implanted many of these over the last 15 or 16, 17 years. So I could say 84% is definitely reality or even higher. And these are in patients a lot of times where nothing else has worked. The medicines have failed. Multiple medicines have failed. Botox has failed. Other treatments have failed, and they're really kind of at the end of the rope. And so, and that second circle, the 3 times greater improvement in quality of life, in those that it works, we certainly see that. And one is that there's very few side effects. I mean, you're not going to feel tired with this. You're not going to have dry mouth or constipation. Basically it just starts working in the background and works quite well. And the amount of improvement is typically significantly greater than one would get through medicine, particularly in those who don't respond to the medicines. And then also, that next circle, the pink one, talks about how it's very worthwhile for the bowel as well. Very high satisfaction for that. And now we're talking about over 450,000 patients, and honestly, I can only imagine it's probably at least 10 times, if not more, number of patients who could have benefited from that. It's one of those things, and one of the reasons why I'm giving this talk is that I do feel like a lot of patients are suffering in silence, and they don't even know there are options here. And if they just knew this was available and had that peripheral nerve evaluation, that test in the office, and they see how much it improves them. I mean, I've had many patients come in after getting the peripheral nerve test, and they're beaming, and they're like, I want this implanted in immediately, the formal implant, because I can't believe how much of an improvement it made for me. So just to know that it's out there and that there is an option, when the typical things that you hear about more often, like medications or Botox, are not working for you, that there is something that's kind of a next level that can work at the source. So, Medtronic is a great company. That's who I work with. That's who does the InterStim and who's kindly helping with this talk. And they have great technology and a lot of different basically ways that one can get help through them and through their app. There's a phone app that you get when you have an InterStim implant, and that is kind of pictured to the left. So that's where the MRI compatibility can be turned on and off feature, and then we can change the different programming. So there's a lot of support. Medtronic is a very big company, publicly traded, and has been doing this for a very long time. So they've kind of ironed everything out where they have tremendous support. And I can say, locally in the Mansfield and Columbus area, the team is top notch and really kind of goes the extra mile for the patients. So you're kind of getting, all of their resources when one of these is implanted. And if there's any issue whatsoever, there's a whole team of people there to help. So that's a great option as well to have. And then so in terms of figuring out which therapy is right for you, it just is something that you have to have a shared discussion with your physician. And so most insurances would like to see medicines tried, and for a lot of people, that's where it ends, is that the medicines are reasonable, they're reasonably priced, the side effects are mild. We have a lot of patients successfully on medicine, but just know that if that's not quite cutting it or not acceptable, then one doesn't have to accept just that's as good as it can get. If as good as it can get is not getting you to the quality of life that you want and that you deserve to have, because your bladder is something that we kind of want in the background and not to take the forefront. Hopefully, it's something that you don't have to think about too much, and if it's affecting your life on a daily basis, then there are ways that we can kind of implement treatments to help that. So next. So this is just kind of some patient testimonials, and so that's a true thing. And so for the InterStim in particular, it doesn't always work for everyone, but for those it works for, we do hear things like this. So and empowering is the word, is that we just want to give you back your life, and so that you can focus on other things besides your bladder or your bowels. And if this can help, then that's a great tool and something that is really important. And then next. So I thank you for your time, and I also thank Medtronic and the Avita team as well for helping kind of organize this talk. And I'm certainly happy to take any questions from the audience, and answer anything that you may have come up during the talk.
Yes, thank you so much, Dr. Wilson, for your time tonight and just everything that you've given to this presentation. For those of you that have questions, please enter them into the Q&A little chat box that you guys have at the bottom of your screen. We can take them that way. We do have a few questions that have come in already. So Dr. Wilson, I'll start out with those. The first being, are there any exercises that may help with bladder incontinence?
The most common one is our Kegel exercises. The best way to describe those is if you're urinating and you'd want to stop the stream midstream, or I've heard it described this way, like let's say that you're in a public place or an elevator or something, and you feel the urge to pass wind, and you clench down on the muscles to prevent that. Those are the muscles you can basically work like an exercise regimen. So doing that, maybe sets of 20, 2 to 3 times a day, certainly can help in the early onset for stress urinary incontinence. For urge urinary incontinence, it doesn't always work. Sometimes the pelvic floor itself is kind of imbalanced. That can really only be diagnosed by a licensed pelvic floor physical therapist. And so there are additional exercises, certain adducting away from the body and abducting towards the body, and certain other kind of core exercises that work the pelvic floor as well. But that usually is in conjunction with a pelvic floor physical therapist, which we do have a set of very good ones at Avita, and I refer patients to them all the time, and with a pretty high satisfaction.
Perfect. And then another one is, are there any natural remedies that help with bladder issues?
That's a good question. Certainly, avoidance of offending foods is very important. Spicy foods can do it. Some people note one food over the other. Caffeine, and the home remedies are a little bit of a mixed bag. Certain people have said that olive oil in some way calms down their bladder. There's a lot of antioxidants in olive oil. I wouldn't necessarily recommend that, but people have tried quite a few things. For those with catheters, sometimes certain flushes of the bladder, acetic acid flushes. But honey, I've heard. I'm not so sure if any of those necessarily have a lot of literature to support them. One big thing that can help kind of everybody is losing weight. If you're over your ideal body mass index, then one home remedy is just trying to reduce that weight a bit, because every extra pound in the belly presses on the bladder and kind of adds to the pressure in the bladder. So not only will that help, a little bit of weight loss help other aspects of life, but it definitely helps in this avenue as well, as it reduces the pressure that's constantly pushing on the bladder.
Perfect. And then just a couple more questions that I've seen. Can you talk a little bit about the testing period with InterStim, and, are there restrictions around showering or activities, or, what you can and can't do with that device?
Yeah, so I would say that is one thing that is maybe a trial of that particular tests in the office is that you will need to kind of limit activities. You don't want to pull out the temporary implant too early because that can kind of affect our ability to accurately assess if it's working or not. So full showers during that period are probably not a good idea. I mean, certainly can have more limited showers. We don't want to get the apparatus wet or risk pulling it out. So it is only a few days. Most patients that have this test and it succeeds, they say it's well worth it, and we try to keep it in as little as possible, but enough to get the kind of information we need in order to make an informed decision about whether the formal implant will be appropriate.
Great. Does interstitial cystitis cause incontinence? I hope I said that right.
It certainly can. Interstitial cystitis is a very complex and actually still to this day a bit poorly or misunderstood phenomenon. It's one of the ways that it causes overactive bladder is that there's inflammation in the bladder. But one would think, okay, well, if there's inflammation, then maybe the same things that calm down the immune system would improve it, but that's not always the case. And so it for some people it responds to one treatment and not another. But it's certainly due to inflammation in the bladder can cause overactivity. For interstitial cystitis, in some people, this may help, but I would certainly try other more traditional therapies for interstitial cystitis and bladder therapies, medications before I would try this first off, because if that's still underlying and the bladder is overactive, then you're still going to have some irritation and other symptoms, even with this type of therapy. So, although it could be like an adjunctive or kind of a therapy amongst several to treat interstitial cystitis, it wouldn't be my first line just because of the complexity of interstitial cystitis and the fact we just still kind of poorly understand exactly what's going on in patients with that. And one day, hopefully, we'll find the root cause and be able to treat it with a singular treatment. But even today, it's kind of elusive for us.
Great. We just have a couple more. Does sitting on a bike seat for an extended time affect either the bladder or bowel?
Yeah, so that's a common question I get and a good one. So, as I'm a pretty avid cyclist as well, and so, the short answer is that the bladder should be far enough away where it shouldn't affect the bladder too much. The nerves that go to the bladder are actually higher up, so what you're sitting on is not the area where the nerves come out of the spine and go to the bladder. They're a little bit higher up. In certainly in men, because biking can press on the prostate. If you irritate the prostate, it can irritate the bladder, and that can cause overactivity. It can cause like a mild prostatitis type issue, and it can affect some of the sensation a little bit to the genital region of both men and women. So it can change sensation, but whether it causes a lot of overactivity is probably less likely. If someone's getting a lot of irritation or urgency and frequency after biking, I would probably look at other things, their hydration status, their electrolyte status, making sure that they're not overconcentrating their urine. Depends on how long you're biking. But usually what we see in biking is more kind of genital numbness or issues and more like prostate type issues in men more than necessarily bladder issues. It's possible, but fortunately the nerves are a little bit away from there and a little bit less affected than with some other exercises.
Great. Just two more questions. One being like insurance. Is most insurance accepted for these type of treatment options?
Yeah, definitely. So that's a big plus is that the nearly every insurance approves this. It's a treatment that's been around, if we're talking about the InterStim, a very long time, and the technology's gotten a lot better. But we're talking about something that's been around, over 30, 35 years at least. And so insurance has recognized this as a appropriate therapy. Insurances a lot of times do like to see what I found is a failure of two medications before they'll approve it. Not always, but I would love for insurances to approve this earlier on because I think, while some patients are getting some benefit from medications, there are definite side effects to the medications. And if we're talking about someone who's, 50 years old, or putting someone on a medication for 30 years has its set of concerns. Whereas this is something that, you have to just change out the battery maybe every 10 or 15 years, but isn't affecting everywhere in the body. It's only treating the problem itself. It's not when you take a medicine, it's getting in the brain a lot of times. It's getting all over the place in the salivary glands. It affects the teeth. If you're not salivating as much, you can get cavities and other things. So when you're taking a medicine, you're taking it in the whole body, whereas this is to the source. So, maybe in time we'll see a little bit better coverage for earlier on in the cycle when someone has overactivity. And some of those other therapies like the tibial nerve may get that kind of coverage. But usually what I'm seeing is that the insurance companies do like to see the patient has tried a couple different medications, has tried behavioral modifications, and that this isn't the first line. But once that's documented, really pretty much across the board with insurances, I have seen it covered by insurance, just like any other, non-elective procedure.
Perfect. Thank you. One last question. I know we're at time. I just want to be respectful of your time and everyone's time.
Sure.
When is a good time to make an appointment, or how do you know that you're ready to kind of have that next consult or come in?
So that's a good question. So really, any time that you're having overactivity in any part of the process, if it's bothering you, particularly if it's waking you up at night, it can be mild during the day. If it just doesn't seem normal or wasn't what it was 5 years ago, it isn't affecting your quality of life, that's a good time to see your primary care or a urologist. With urology, the primary cares have so many medical issues usually to go over that this sometimes gets pushed to the bottom or not discussed. So, if someone has diabetes and heart trouble or lung issues, and so that takes up so much of an appointment time. So sometimes it's best just to go to a urologist because that appointment will be solely focused on the overactivity of the bladder, and so we can kind of really focus on that issue. Whereas the primary cares do a great job, and they do a wonderful job. It's just they have so much to discuss sometimes, and in a short period of time that this sometimes is not the focus of the appointment. So it's certainly worthwhile bringing up to your primary care. They're very well versed in the medications. The primary care doctors don't really give Botox or do something like InterStim or any sacral neuromodulation, but they can start on a medicine and get that process going. Discuss behavioral modifications, and at any point, if you feel like you want the problem looked into in more depth, then a urologist is definitely a good resource. And really, you can schedule an appointment with Avita Urology just by the information right there. You don't need a primary care referral, and we're happy to address this on a specific need basis and an individual basis as well.
Great. Thank you so much, Dr. Wilson, for tonight, for all of your information and your guidance and the questions answered. We really appreciate it. And for those that are on and attending and listening, thank you so much for coming this Wednesday night. We really appreciate it. If you missed any part of the presentation, you will get a recording of it tomorrow from the Zoom email. And we're just so thankful. Again, if you haven't answered the poll question on your screen, please do so before leaving. We'd like to capture that information. And I wish you all a wonderful night and a great weekend ahead. Thank you
Thank you
all.
very much, everybody. Yeah.